Hello and welcome to this episode of the VJNeurology podcast, where we will be joined by Professor Mona Nada to discuss the latest updates in the prevention, diagnosis and treatment of cluster headache. Cluster headache is a rare but devastating primary headache disorder, often described as one of the most severe pain conditions in medicine. Categorized by recurrent attacks of severe unilateral head pain, accompanied by autonomic symptoms such as lacrimation and nasal congestion, it has a profound impact on patients' quality of life. Despite this, cluster headache remains under-recognized and challenging to treat, making ongoing research and expert clinical insight essential. We are delighted to be joined by Mona Nada, who is a professor of neurology at Cairo University and co-chair of the Cluster Headache Special Interest Group of the International Headache Society. So, without further ado, let's begin the discussion. Professor Nada, thank you so much for joining VJNeurology on the podcast. Can you begin by discussing the prevalence and etiology of cluster headache?
Well, first, I would like to thank the VJ Journal of Neurology for giving me this chance to talk about cluster headache. Actually, cluster headache, the prevalence of cluster headache is 0.1%, which is, yes, a rare disease, but it's a very devastating headache, and it's a very severe headache that it's sometimes called the suicidal headache. As regards the gender, it's more prevalence in males. It counts nearly 4-1. But actually, this gap may be due to the lack of epidemiological studies related to cluster headache and the other trigeminal autonomic cephalalgias. As regards the age, actually, it's usually at the age of 20 to 40 years old. So it's a very devastating disease in the period of the adulthood and the working period of age. The geographic distribution is actually not that clear due to the lack of different countries having their own prevalence and epidemiological studies.
Thank you. And what advice do you have for practicing clinicians when diagnosing cluster headaches?
Well, actually, we had this diagnostic delay, and this is a great problem that usually the patients with cluster headache, they will go for the ophthalmologist having this strictly unilateral headache, which is very severe with autonomic features like nasal lacrimation, nasal congestion, rhinorrhea, ptosis. So they usually visit the ophthalmologist first or the ENT. And the misdiagnosis actually causes this diagnostic delay and diagnostic inertia. So I advise people to be very well aware of the classic picture of the cluster headache, which includes the strictly unilateral headache that lasts maximum to the 3 hours, which differentiate this headache from the migraine, which may last for 3 days. And actually, it has this rhythmic circadian rhythm of recurrence that it can happen each day, twice or 3 times per day. The knowledge of the diagnostic criteria will just fasten the diagnosis and will shorten the disability and the suffering of the patients. Also, differentiating this headache from migraine, which is usually misdiagnosed. The patient are usually misdiagnosed as having the migraine because it's common, it's very prevalent, it's very well known, and it's actually completely different from the cluster headache. The other point is when we are facing patients with a primary headache disorder, as by the guidelines, we have to do imaging when we suspect secondary headaches. And this is very important in cluster headache attacks. So if we have this patient, the male patient in the 20 to 40 years old with this strictly unilateral headache and the autonomic features on the same side of the headache, we have to do imaging, specifically MRI. And sometimes we can use also the functional imaging, because if we go to the etiology, usually we have this evidence that the hypothalamus, especially the posterior part of the hypothalamus, is involved in this type of headache. So we have to rule out the secondary causes and the affection of the pituitary of the hypothalamus as a secondary cause of a primary headache. The neurotransmitters play a role in the pathogenesis of the cluster headache. And that's why when we are questioning a patient with unilateral headache, we have to ask, when does this happen in the day? If this have a circadian rhythm. And usually this is the case in the cluster headache. The patient have their biological clock that they are having this severe attacks, this devastating headache, usually at 2 to 3 a.m. And this is related also to the hypothalamus, to the clinical features of any type of headache, especially the cluster headache and attacks, it's very important to listen well to the patient and ask all the questions related to headache. So we can, by history, differentiate attacks, especially cluster headache, from the other types and from the secondary types.
Are there any recent trials or guidelines you think every clinician treating cluster headache should be familiar with?
We have this new guidelines with the European Academy of Neurology that published the guidelines describing the new advances in the pathogenesis and the updates in the treatment. We have the new lines for treating cluster headache, like involvement of the anti-CGRPs antibodies. And this is, I think, it's the new era in the treatment of headache in general, and specifically in migraine and cluster headache. And following these guidelines, we can know which proper abortive treatment that we can use in cluster headache, because of this carries the misjudgment sometimes of using the oral triptans, which will have this very short headache with a very long acting drug. So we usually use as an abortive treatment either the oxygen mask with a specific characteristic that it's 100% oxygen with non-rebreathable mask for 15 minutes. And we can use the triptans, but we can use the triptans using the intranasal or the subcutaneous, because, as I mentioned, it's a very short duration of the headache. So the oral are not used in the cluster headache. Also, non-steroidals, they don't have a role. And this sometimes adds to the medication overuse and the gastritis and the side effects from the non-steroidals, anti-inflammatory drugs, which will not add benefit for our patients. The other part of the guidelines is the prevention. We usually say that if we can prevent this headache, this disabling headache, this is a great success, because we have the two types of cluster headache, whether this is an episodic that happens in a part of the year, and we have more than 3 months between the episode and the other attack, and there is a remission period of more than 3 months, or the unlikely that the patient have the chronic cluster headache, which is a very severe attacks that have no remissions in between or a very short remissions. So the prophylactic treatment is very important in dealing with such patients. We can use the calcium channel blockers, the verapamil, topiramate, melatonin, the anti-CGRPs can be used. This very strict guidelines will help us to help the suffering of the patient and have a very clear and proper evidence-based medicine use drugs for those patients.
That's great. Thank you for sharing those updated guidelines. You were also co-chair of the Cluster Headache Group in the International Headache Society. What are the aims of this group, and can you highlight any ongoing work?
Fortunately, the International Headache Society have this special interest groups. They have maybe 12 groups. Luckily, I'm the co-chair of the Cluster Headache Special Interest Group with Professor Stephen Evers from Germany. We have experts in the cluster headache, 19 members from all around the world. We are interested in the pathogenesis of the cluster headache, the new genetic elements, the awareness of the young neurologists and the general population about the cluster headache and the other trigeminal autonomic cephalalgias. There are ongoing studies now that we're trying to start and initiate, knowing more about the drugs available in the high and low income countries to help those patients. We have the campaign that is supported by the International Headache Society with the videos with different languages that are just educating people about the diagnosis, the clinical picture, the investigations needed, the proper treatment, how to go to a physician and a headache specialist to avoid these attacks and reduce the suffering.
Moving on to treatment, monoclonal antibodies targeting CGRP have emerged as an important development in cluster headache management. Could you discuss the role of anti-CGRP therapies and whether there are ways to predict which patients are most likely to respond?
In the era of the anti-CGRP, which is the new drugs that are approved for the migraine, we have already the galcanezumab that is approved for the episodic cluster headache. But unfortunately, the other anti-CGRP did not take the approval. The studies did not show that the patient with cluster headache will benefit from this anti-CGRPs and also for the chronic type of cluster headache. So we need predictors that we can say that this patient will be a good responder to the anti-CGRP or not. And this was done in one of the studies that recently published, and they found that the older age, the patients in European countries, the frequency of attacks, all these are carrying bad predictors for the response to the galcanezumab in patients with episodic cluster headache. We hope that we have more and more studies that are studying and seeing the effect of the anti-CGRPs in the cluster headache with both the episodic and the chronic types.
Finally, looking ahead, what do you see as the most promising developments on the horizon for patients living with cluster headache?
Well, in my residency in 1989, we don't have this, at that time, we didn't have the specific treatment for migraine or for headache. So I think we are in a very important era for headache in general, and especially for migraine. We have drugs that are approved already for the abortive or the prophylactic treatment that are migraine specific. And this change in the landscape of treatment of migraine, including the anti-CGRPs, the backup that is just going neurotransmitter now, and maybe in the upcoming years in the future, we will hear more and more as treatments for migraine-specific treatments available. And also for the cluster headache, there are ongoing researches digging in the pathogenesis and trying to have a specific drug used for those patients for cluster headache and other attacks. So in my opinion, that the landscape is changing completely within the last 5 years, and that the upcoming future will carry more and more hope for our patients to have more specific treatment with less side effects and higher efficacy, more awareness for the general population and the physicians. So this will help to have more and more patients having proper treatment and less disability and better quality of life.
That's all my questions. Thank you very much, Professor Nada. Thank you for listening to this episode of the VJNeurology podcast. Head over to VJNeurology.com for more content on cluster headache and other headache disorders. Be sure to follow us on X at VJNeurology and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.